Retinal detachment is an ocular emergency where the retina, which is the thinnest with a very thin tissue in the backside of the eye, when it gets detached from its original position, that's called a retinal detachment. If it gets undetected or untreated, it will lead to permanent blindness. Now, there are various reasons for this retinal detachment, or rather types of retinal detachment. One is that regmatogenous retinal detachment, that happens when there is a retinal tear and the vitreous fluid goes underneath the retina and detaches the retina. That's the most commonest type of retinal detachment. That is called a regmatogenous retinal detachment. Now, coming to the second commonest cause of retinal detachment or type of retinal detachment, it's a tractional retinal detachment. Now, tractional retinal detachment occurs due to some scar tissue pulling the retina tangentially. There's a traction on the retina or a pull on the retina, which causes the retinal detachment, of which the most common is the diabetes. Other causes are there, but the most common cause of tractional detachment is diabetes. And coming to the last type of retinal detachment, that is an exudative detachment, where the fluid accumulates underneath the retina. The causes are some inflammation, eye injury, or some tumor in the eye, which can cause a exudative detachment. The symptoms what the patient sees if one has got the retinal detachment is, uh, there will be dimness of vision. A part of the field of vision, or rather the patient complains a curtain is falling down. Curtain falling in a sense, one side of the field of vision is lost. Some part, either the superior or the inferior part, one cannot see. There is floaters or flashes of light. Sometimes the floaters increases and there is a very frequent cause of flashes. Flashes of the light means one sees the light passing through, either from up to down or side to side, and it occurs very frequently. And obviously, sudden loss of vision is the most commonest sign or symptoms of retinal detachment. One has to be very careful, like retinal detachment doesn't occur bilaterally in the both the eyes. It will be one eye that gets affected at a time. Sometimes what happens, it gets undetected because the other eye is doing well. It compensates the loss of vision in the detached eye. One has to be very careful and actually see with one eye at a time uh, to understand that something is going wrong. It happens mainly, it's an aging change, as I was mentioning. With the age, the jelly inside the eye, which is called a vitreous, it liquefies and contracts. And when it contracts, it pulls the retina and causes a regma, that is a break in the retina, which causes the retinal detachment. So that's like more common with aging. And other risk factor is somebody who has a myopia will might get a retinal detachment, because that's common in the myopic population. And the other reasons of the retinal detachment is diabetes. So it's common in a diabetic population, it's common in a myopic population, and obviously the most common is the age related. With age related, the detachment happens. Regarding diagnosis of retinal detachment, it is mostly a clinical diagnosis. One has to do an indirect ophthalmoscope to diagnose a retinal detachment. Obviously, if we need to show the patient what is going wrong inside the eye, we have to do an ultrasonography of the eye, or we need to take a picture of the retina. That is called a fundus photograph. So, fundus photograph of a normal eye and a detached eye, you can actually show the difference, that what is going wrong. And sometimes we can take the picture of the retinal tear which has caused the retinal detachment. So mainly it is a clinical diagnosis, and if I take a help of the diagnostic tool, it is the ultrasonography and the fundus scanner. This is an ocular emergency and it needs to be treated as soon as possible, because more we wait, the retina will get stiff, and there is a chance of recurrence of detachment after the surgery also. This is one part. Another is, if the retinal detachment goes, or it's an old detachment, the chances of visual improvement is compromised. So we have to act very fast whenever this alarming signs and symptoms appear, like floaters, flashes, curtain falling down. We need to consult a retinal surgeon as soon as possible. As far as the treatment goes, there is two major types of treatment. One is called as scleral buckling surgery, where we give a silicon band which pushes the retina from outwards. That's an external approach. And mostly what we do a vitrectomy surgery where we push the retina from inside, from the position from where it has been dislodged. That is an internal approach. So mostly what we do is a vitrectomy surgery. But in a surgery, we need to know certain things like in a vitrectomy surgery, we remove the vitreous, that is the jelly, attach the retina to its original position. We do laser and then put a supporting agent. Now, the supporting agent or the tamponating agent, what we call, is it can be a gas. If we put a gas, then it gets absorbed inside the eye. There is no need for a second procedure. But many a times we need to give a longer supporting agent or a longer acting tamponade agent that is called a silicon oil. If we give a silicon oil to settle the retina, to attach the retina, then that needs to be removed after 3 months. At least we keep 2 to 3 months, and after that we remove the silicon oil when the retina is fully attached. And another thing I would like to mention, that after the retinal detachment surgery, the patient needs to keep his head or eye in a specific position so that the retina gets support from the tamponating agent. That is the silicon oil or the gas. That's mainly an head down position or a prone position. That is, you need to keep the head down, whether in a sitting or in a lying position. When the retinal detachment has been diagnosed, the first thing I would suggest that the all patients needs to undergo the surgery as soon as possible. If it is a partial detachment, we advise certain position before the surgery so that the retinal detachment doesn't gets worsened due to the position. So they should take rest before the surgery. So this is like a pre-operative advice. Obviously, post-operative advice is one has to take rest because a certain positioning of the head is required after the operation. And obviously, we cannot take bath, because if the water goes inside the eye, operated eye, there is a chance of infection. That needs to be maintained for at least that restriction will be there for first 2 weeks of the surgery, along with the positioning of the head and eye. And obviously, the medicines what we give after the operation needs to be instilled according to the directions. The first complication, I would say, if the patient is not aware of the retinal detachment and the retinal detachment gets diagnosed and after some time, and when the retinal detachment is an old one. So if in an old detachment, obviously the chances of visual recovery is not that great. And at the same time, the visual prognosis also is not good. So this is one thing the patient needs to be aware of, that the early surgery is the best treatment, and surgery is the only way. And sometimes after doing a good surgery also, there is a recurrence of retinal detachment, because the retina being a very thin tissue, new hole appears, sometimes fibrosis appears. We say that there is some scar tissue which redetaches the retina. So if that is the case, we have to reoperate the patient, and it needs a very quick monitoring, because sometimes what happens, the oil which we have given inside the eye, it emulsifies or liquefies, and that might lead to increase in intraocular pressure. Sometimes if it is not emulsified also, the eye pressure increases. So we have to, after the operation also, we have to monitor this patient, seeing whether the retina is attached or not, whether it is getting redetached, or the eye pressure we have to monitor, because sometimes the eye pressure is very high. We need to give medication for that. Retinal detachment is can definitely be prevented, because As I was mentioning, if it is an aging thing, it occurs due to contraction of the jelly. That is something which we cannot prevent. But the retinal detachment happening in a myopic patient, that is the patients who have minus power, if they do a routine checkup, we can actually detect there is some weakness in the retina or the retinal thinning, which we call a lattice degeneration. And if there's a positive family history, we do a laser to prevent such a detachment. This is like a preventing a retinal detachment in a myopic patient. The laser actually plays a very important role. At the same time, the tractional retinal detachment, which happens in a diabetic patients, if the diabetic patients have undergo a very regular eye checkup, we can actually prevent it by doing a laser at proper time.